probably heard about remote patient monitoring, or RPM. It's this huge promise to revolutionize healthcare, right? Keep patients safer at home with all this great tech. But here's the thing, there's a paradox. Why do so many of these high-tech systems, well, fail to actually make people healthier? Today, we're going to dig into that. This is what some people call the efficacy paradox. It's this weird gap where we have all the right intentions, we're monitoring patients, we're collecting data, but it doesn't automatically lead to better health. We have all this amazing technology, but the results, they're all over the place. So the real question isn't if we should monitor patients, it's how we should be doing it. And believe me, the stakes are incredibly high. Just look at this number. That's the readmission rate for Medicare heart failure patients within just 90 days of going home. Almost half. It's this massive, painful cycle of cost and suffering for patients and their families. This right here, this is the problem that a truly effective RPM system has got to solve. So, how do we fix this? How do we break that cycle? Well, the solution isn't just throwing more technology at the problem. It's about using the right technology. And it turns out success really hinges on this simple but incredibly powerful framework, a kind of design triad that unlocks what RPM is truly capable of. And this triad is it's brilliantly simple. First, you've got specificity. Are we actually monitoring something that's directly tied to the disease itself? Second, objectivity. Are we using hard, quantifiable data instead of just asking a patient, so how are you feeling today? And third, accuracy. Can doctors actually trust that the data is precise and reliable? You get these three things right, and honestly, the whole game changes. This really breaks down the two different ways of thinking about care. On the left, you've got the old way, the subjective model. It waits for a patient to report symptoms. I'm feeling tired, or I'm a little short of breath. The problem is, by then, it might already be too late. But on the right, you have the objective model, the one guided by our triad. It uses real data to find those early warning signs before the patient even feels sick. It's really the difference between reacting to a house fire and seeing the smoke before a single flame appears. And you can see how this all connects, right? It's not magic, it's a logical chain reaction. You start with a better design, choosing to monitor that specific, objective data. That, in turn, gives you better data. Better data leads to better decisions from doctors. And what do better decisions lead to? You guessed it, better outcomes for patients. It just makes sense. Okay, so this all sounds great in theory. But how does it actually hold up in the real world? Well, a huge clinical trial back in 2019 by a team led by Dr. Sung gave us the perfect test. They put these two models, the subjective and the objective, head-to-head with a group of really high-risk heart failure patients. The setup was really clever. They took 225 patients and split them up. The first group, the control group, got the usual standard of care. Doctors adjusted their medications based on how patients said they felt. The other group's doctors, they had an extra tool. They had objective data from something called acoustic cardiography, specifically measures that track how efficiently the heart is pumping. So you basically had one group's treatment guided by feelings and the other guided by hard data. So what happened? What happened when you put these two completely different models of care to the test for a full year? Well, the results, they were nothing short of stunning. For the entire group, the patients whose care was guided by that specific objective data saw a 39% drop in the relative risk of being rehospitalized or dying. Just stop and think about that for a second. Almost a 40% reduction in terrible outcomes simply by giving doctors better data to work with. But it gets even crazier. When they zoomed in on the highest risk patients, the ones everyone expected would end up back in the hospital, that data-driven approach led to a 68% reduction in risk. This just shows you the incredible power of using data to find the sickest patients and intervene before things get bad. Let's just look at the hard numbers here. If you look at that hazard ratio column on the right, any number less than 1 means a lower risk for the group that got the objective data. And as you can see, down the line for every single metric, the objective data group did way, way better. We're talking risk reductions of 39%, 68%, and even a 67% drop in the chance of dying from any cause for those high-risk patients. The data just speaks for itself. It's undeniable. And hey, you don't have to take my word for it. The researchers themselves said it best. They concluded that focusing on these objective measures might be a better strategy than the old way of just asking patients how they feel. This is what the shift from subjective to objective care looks like in the real world. So the big question is, why? Why did this work so well? Well, this chart here is basically the smoking gun. That objective data was an early warning signal for fluid buildup, which is a huge danger for heart failure patients. Because they had that signal, doctors in the data-guided group prescribed more diuretics, the drugs that prevent that fluid buildup. The other group, who didn't see the data, made fewer of those critical adjustments, and their patients had worse outcomes. It's that simple. The objective data led directly to better, earlier decisions. And here's the really important part. This isn't just about heart failure. That design triad, specificity, objectivity, and accuracy, is a universal rule. It's the key to making remote monitoring work across all kinds of chronic diseases. I mean, just look at diabetes. Continuous glucose monitors give you accurate, objective data every few minutes, and they're now proven to be way more effective and even cheaper in the long run than just doing finger sticks now and then. Or for lung diseases like COPD, we're seeing a shift away from symptom diaries to monitoring objective lung function to catch problems earlier. The pattern is exactly the same. Specific, objective data always wins. So if there's one thing you walk away with today, please let it be this. The real value isn't just in the act of monitoring a patient. It's not about checking a box. The value is created by the clinical quality, the specificity, and the objectivity of the data we choose to collect. And that really leaves us with a final, critical question for the entire future of healthcare. Should our health systems just pay for the simple act of collecting any old data? Or should we evolve to a smarter model where we actually invest in and reward the collection of high-quality, validated data that is proven to keep people healthy and out of the hospital? That's the choice we have to make.
Bye!